Welcome to Pulse and Pressors, where critical care gets crystal clear. Today, we'll focus on stroke volume variation, SVV, a dynamic, physiology-based metric that helps answer the question every intensivist and anesthetist faces. Will this patient respond to fluid? We'll cover the calculation, how SVV is identified using an arterial line and pulse contour analysis when the values are reliable, and the interventions to take when SVV is high or low. Stroke volume variation is the percentage swing in stroke volume that occurs with positive pressure breaths. It leverages natural heart-lung interactions. Mechanical insufflation changes venous return, and thus stroke volume. Large swings mean the patient is on the steep portion of the Frank-Starling curve and will likely increase stroke volume with a fluid bolus. Small swings suggest the patient is preload independent. Mathematically, SVV is the difference between the maximum and minimum stroke volumes over a respiratory cycle divided by the mean stroke volume, expressed as a percentage. Modern monitors calculate this beat to beat using pulse contour analysis, then average it. Clinically, we use the resulting percentage to guide decisions about fluid responsiveness. On a bedside arterial waveform, you can often see respiratory variation. Systolic pressure and pulse pressure rise and fall with inspiration and expiration. Pulse contour monitors convert the waveform into continuous stroke volume estimates and calculate SVV. If you don't have a dedicated SVV readout, look at pulse pressure variation as a surrogate. The physiology is the same, and all you'll need is an arterial waveform. SVV is powerful, but only under the right conditions. It works best in fully sedated, mechanically ventilated patients without spontaneous efforts, with regular sinus rhythm. Low tidal volumes, arrhythmias, open chest surgery, very high PEEP, or large changes in chest-abdominal compliance all invalidate SVV. If the context isn't met, dynamic tests like passive leg raise or end expiratory occlusion are preferable. While exact cutoffs vary by study and monitor, an SVV above about 12 to 13% is commonly used to indicate fluid responsiveness. Values below about 10% usually mean the patient won't increase stroke volume with fluids. Between 10 and 13 is a gray zone. Perform a dynamic test such as a passive leg raise or tidal volume challenge to confirm. Always pair SVV with clinical endpoints and other hemodynamics. If SVV is high, a fluid bolus is the physiology-directed next step, but do it intelligently. A 250 to 500 milliliters bolus is typical, then reassess stroke volume, or SVV. A passive leg raise is a great reversible test. It transiently increases venous return. If stroke volume rises, the patient is fluid responsive, and you can give fluids. If passive leg raise is negative, avoid fluids and search for other causes of hypotension. When SVV is low, further fluid often won't help and may cause overload. If the patient is hypotensive with low stroke volume, think vasopressors to improve perfusion pressure, or inotropes if contractility is poor. Always reassess pump function with echo and check for non-volume causes. Tamponade, right ventricular failure, myocardial infarction, or vasoplegia. Know the limitations. SVV is invalid in arrhythmias and spontaneous breathing. Low tidal volumes blunt respiratory variations. A tidal volume challenge can help. Open chest or very high PEEP states and elevated abdominal pressure alter venous return mechanics and make SVV unreliable. Right ventricular failure is another trap. Preload dependence is different, and SVV can be misleading. Here's a simple workflow. When SVV conditions are met and the value is high, confirm with passive leg raise or give a small fluid bolus and reassess. If you're in the gray zone, do a passive leg raise or tidal volume challenge. If SVV is low, avoid giving fluids blindly. Use pressors or inotropes. Here's a simple workflow. When SVV conditions are met and the value is high, confirm with passive leg raise or give a small fluid bolus and reassess. If you're in the gray zone, do a passive leg raise or tidal volume challenge. If SVV is low, avoid giving fluids blindly. Use pressors or inotropes guided by echo and clinical status. When SVV can't be trusted, passive leg raise, end expiratory occlusion test, or a tidal volume challenge are excellent dynamic alternatives. A tidal volume challenge can help confirm fluid responsiveness by briefly raising the tidal volume and watching for changes in stroke volume variation. If SVV decreases, the heart's still fluid responsive. End expiratory occlusion maneuver is a maneuver performed on a mechanically ventilated patient to predict fluid responsiveness. It briefly pauses ventilation at the end of expiration for about 15 seconds, preventing the inspiratory drop in venous return and acting as a temporary, reversible internal fluid bolus. If the patient's cardiac output or pulse pressure increases by more than 15% during the maneuver, they are considered fluid responsive and will likely benefit from a fluid bolus. Here's your one-page cheat sheet. The formula, the conditions for valid measurement, thresholds, and quick actions. Save a screenshot for quick decision support at the bedside. This is Pulse and Pressors, providing a daily education on the marvels of the human body. Quick question for the team. What SVV threshold do you use in your ICU? And which dynamic test do you prefer when SVV is unreliable? Drop your thoughts in the comments and don't forget to click to subscribe.